Okay, it's my pleasure to call this session to order today. Good afternoon, everybody. You are in the breakout session, The Spectrum of Food Insecurity and Disparities in Oral Health. It's my pleasure to be your moderator today. My name is Kelly Cantor. I work for the American Dental Association. I'm the manager of community-based programs. And as a longtime public health professional, I'm especially excited about today's topic, particularly as it relates to care coordination in the oral health world. I'm going to start with a little housekeeping today, and you can see it up on the screen. You are all muted, but you can certainly raise your hand and type in the chat, and I encourage you as we go through our hour to keep putting questions in the chat. And if we have time, we will get to those at the very end. To ask the speaker a question, please use the Q&A window. As I said, we'll try to save a little bit of time at the end for questions. To receive CE credit for the session, complete the survey shared in the chat. The survey links will also be emailed to attendees, and I believe that that link will go in the chat near the end of our session today. And when the session ends, attendees will be automatically routed back to the lobby to choose their next session. Okay, wonderful. So for today's session, we are going to be covering the following objectives. We're going to be looking at how community dental health coordinators, or CDHCs, can address food insecurity with underserved populations. It's going to be described how CDHC training conditions dental professionals to identify and converse with allied health groups about food insecurity for underserved populations. And then finally, we'll be looking at how the CDHC program increases awareness of the social drivers of health. It's my pleasure to introduce today's panel, Miss Gloria Aldana, Dental Program Manager of Zufall Health, Dr. Tonya Cook, the Chief Executive Officer and President of Ivy Hill Dental, Dr. Andres Escobar, Community Dental Health Coordinator for Zufall Health, and Dr. Dane Grover, the Senior Director of the Council on Advocacy for Access to Prevention with the American Dental Association, and also the National Director of ADA's Community Dental Health Coordinator Program. It's my pleasure to turn it over to Dr. Grover, who will start us off with her presentation. Thanks,
Great.
Dane.
Thank you, Kelly, and welcome everyone. I hope you can hear me just fine. I'm delighted to be able to share this information with you as sort of a foundation for the ongoing conversation of dental professionals such as hygienists and dental assistants, learning about this wonderful program and the ability they have to gain insight as to the community health worker skill set. We're going to talk a little bit about the program, the curriculum, and then we will turn it over to those who are going to talk about how they're implementing this and the value that they are finding in moving this forward. Next slide, please. So in January of 2012, the American Medical Association had a commentary that talked about what patients really need. And they need assistance with their social problems. They need connections to available resources in the community, including, but not limited to, transportation and translation of the increasingly complex language of medicine. So prior to joining the American Dental Association 9 years ago, I was an FQHC dental director and clinician in Michigan. And for the first couple of years, this sort of thing just sort of was not on our radar. The lights were on, the staff was there. Where are the patients? And how can we engage patients more? And how can we engage those that need oral health care the most? Well, because the dental community typically doesn't see things like these issues the way the medical community does. And so case management, while it's well recognized in the medical world, has not been as evident until now in the dental world. Next slide, please. Fantastic. So identifying social needs is a critical component of patient care. It isn't just about them showing up, understanding what clinical procedure will be done that day, or their ability to impact and comply with preventive services and home care suggestions that you lay out for the patient, identifying their social needs that can be driving health outcomes. And that includes compliance with a treatment plan, the ability to have a treatment plan completed. This includes physical environments, health behaviors, and social economic factors. Payers and states are leading the way, and they have been for a while, on collecting this kind of information, accounting for this kind of information, but providers less so. But the dental world is catching on, and this is what is so important about the Community Dental Health Coordinator program. Next slide, please. So the American Dental Association asked years ago, what if a dental professional had community health worker skills? Community health workers are valued members of the healthcare community. I worked with case managers and navigators for 12 years at the health center, and they're good people. But they didn't know anything about the dental world. And this is where we're seeing a gap. We're seeing a gap in the engagement of patients and additionally, some allied health professionals to fully understand the value of oral health and help those patients be connected to care. So years ago, the ADA asked, what if a dental professional had community health worker skills? Next slide, please. And that is about identifying those barriers that we had in the previous slide. So the CDHC program was designed by participating in several focus groups, some of which included community health workers who shared what they did. And the dental professional community that was on this work group to design the curriculum took those issues very seriously. So the curriculum deals with some very important information that community health workers know very well. The dental world has known less well. Community mapping, motivational interviewing. The motivational interviewing in the CDHC program is a deep dive. It is not a weekend of reading through a few articles. It is a several months long module, and the reflection papers that we get from graduates, as I'm sure you hear at Zufall as well, are very meaningful. How to do a home visit, how to evaluate credible data. How can a dental professional be a change agent within a community, similar to what a community health worker does? But the valuable part of CDHCs is that they have dental foundational knowledge. Now, they don't stop being hygienists or assistants, but they have more meaningful and relevant engagement in the community, and those additional people that need guidance in navigating patients into care benefit from CDHC collaboration. Cultural competence, case management, these are part of the curriculum of the CDHC program. Next slide, please. Connecting with pregnant women. Not many people know outside of the dental community that dental services are safe all 9 months for pregnant women. This is a policy at the American Dental Association. This is where knowledgeable case managers like CDHCs can fully engage with OBGYN communities, nurse practitioners, anyone connected with pregnant women, family medicine, who can assure them confidently that the American College of Obstetrics and Gynecology works with us closely. We have a joint consensus statement, and working with a faith-based community, again, to improve that circle of trust, which is what community health workers do and what community dental health coordinators do. This is part of a skill set that is learned in the curriculum. And we're so proud and delighted that Zufall, the first FQHC to offer this program nationwide, engages in this kind of relevant material. Next slide, please. Dental professionals can make an impact in a variety of ways. It isn't just about rendering clinical care. It is about supporting and coaching and advising and guiding families and those who also are engaged in coaching and guiding families into care. We've evolved from handing patients a sheet of paper and saying, here, call one of these numbers. We've evolved from having a medical-only site hand a business card to a busy mom with 2 or 3 kids and tell her to make the appointment and expect her to understand what happens at that next visit, and expect her to be able to understand what the procedure is going to be and why it's important. So dental professionals can make a wider and deeper impact, not just in the public space, but in the allied health professional space as well. Next slide, please. CDHCs can address food insecurity because the curriculum engages them in looking at populations who are juggling a variety of crises. And one of those crises is going to be food insecurity. This is something that is increasingly important. How do we expect patients to comply? How do we expect patients to keep appointments? How do we expect patients to understand the value of oral health when there is food insecurity? When you are hungry, are you really hearing a message delivered to you by a professional or by anyone? And this is where CDHCs can be extremely helpful by collaboration with other allied health professionals, by noticing what patients need, listening in between the lines, and being culturally competent with the stressors that are in the lives of these individuals. Next slide, please. So this is a lot of information. Feel free to email Kelly or myself if you have questions about the CDHC program at Zufall or any other educational location. We are delighted to answer questions and send additional information. Thanks to all of you for attending our session today, and I will turn it back to Kelly to introduce our next speaker. Thank you.
Okay, wonderful. Thank you, Dr. Gerber, on that great overview of ADA's CDHC program. I'm going to ask our panelists, our very esteemed panelists, to talk a little bit about, how do you see food insecurity sort of relating to oral health? And tell us a little bit about what you're doing at your organization. So Dr. Cook, again, the CEO and president of Ivy Hill Dental, can we start with you?
Absolutely. Happy Friday, everyone. I have 23 years in the federally qualified health centers in the state of New Jersey, spanning over 5 counties. And over my time at the federally qualified health centers, every area that I've worked was a food desert. So it was really concerning how our patients were receiving their food. Most of them, I would say a large percent, would go to bodegas, corner stores for a majority of their food because of transportation issues. Recently, we have a great partnership with the Department of Health in the state of New Jersey, and they had a grant. It was a nutrition, oral health, and obesity grant. And we had maybe about 15 participants all throughout the state of New Jersey. And it was a great opportunity for us to see our patients to age 11, 6 to 11. And when they came for their dental visit, we took their BMI and we provided counseling, nutrition, and it was 3 visits. After the 3 visits, they were allotted 3 months of free fresh vegetables and fruits. It was an amazing program. Hats off to our dental director for the state. We haven't had one in many years, Dr. Hayes. It was an outstanding program, but for my organization, what I found is a lot of the parents did not participate. So I am lucky enough to have a care coordination group that was able to outreach and help reach out to the parents, provide the education. And I don't know if it was pride, which could have played a factor in it, or just they weren't interested, but we did not have 100% participation like I would have expected. And in the area that I serve, there are no supermarkets. So you have to travel. So to be able to find a fresh fruit and vegetable, and we have a lot of farms in the area, and we had a fresh fruit and vegetable area in town, and they did not take advantage of it. So it was really heartbreaking. But what we found during this time, and of course it was during COVID, so a lot of kids weren't as active, obesity went up, and the caries risk assessment was much higher. So of course we know it goes hand in hand, because nutrition, of course, the first thing is in the mouth. So if we're not providing the proper education to our patients, resources, you are going to see effects in the oral health. So it was a great opportunity, and Zufall was a part of that. And I know I have partners on here from Zufall, but it was a great opportunity, and nutrition should be one of the things that we give our patients when we see them in our centers.
Thanks, Dr. Cook, and that is excellent because so much about the body affects the mouth, and I would agree that addressing the insecurity and the nutrition is a great thing to do for improving oral health. I think we had Gloria on here, but I'm not sure I see her anymore. So Andres, if I can call on you. Andres is a community dental health coordinator at the Zufall Health Center. And if you heard this morning's plenary with Dr. Hayes, he talked a little bit about how Zufall actually had their first graduate cohort, and they're into their second one now. And they are our very first FQHC running the ADA's implementing the ADHC curriculum. So Andres, or rather I've got Gloria here. Gloria Aldana, Dental Programs Manager, Zufall. Can you talk a little bit about how you sort of address how Zufall is sort of using this care coordination role to address food insecurity?
Hi everybody. So in the clinic, in conjunction with the program with the Department of Health, they once the children had already their 3 BMI measurements, they were automatically eligible to get food. We were able to distribute over 50 food deliveries to them. We found out that it was a lot of, I guess people wasn't sure, like that never happened to them. So they were a little bit insecure at the beginning. We have to actually talk to them, walk with them through the whole thing. We even did the application online for them while we had them on the phone. So we actually had to meet a lot of the gaps to be able to deliver the food to them. The population we work with, they're not, the level of technology and literacy wasn't the best, so we had to go above to meet them where they were to able to help them, for them to get the food delivery.
Okay, interesting. And I'm definitely going to kind of come back to you all after we hear from Andres. I think a lot of folks here are really interested in what you're doing and might want to replicate similar programs, but we'll get to what are the barriers and challenges you're running into to even doing this, because the will is there, and sometimes these barriers get in our way to serve our patients the way we want to. So Andres, you're up. Andres has a unique role because he is on the front line as a community dental health coordinator. So Andres, can you tell us a little bit about what you see and how do you think the role of the CDHC is valuable in addressing food insecurity?
Yes, thank you, Kelly. We really happy to work with the community here at Zufall Health Center with in the state of New Jersey. Like Dr. Cook was saying, that we work on the program that the Department of Health in New Jersey work with all the FQ Federal Qualified Health Centers here in New Jersey. We saw that a lot of kids, a lot of people in the whole nation after the COVID, that was a double of food insecurity. So in this program, we managed to contact the community and work with them using motivational interviewing techniques that we developed during those years that we work with these patients. We try to make them aware of the problems that they have in overall health and oral health problems that they particularly have, and the limited access they have, these communities, vulnerable communities that they have no access to all health services. So we had to improve, and we try to improve their outcomes for these minorities and these underserved populations, as Dr. Heiss was mentioning this morning. So New Jersey, the Department of New Jersey has a whole variety of programs like the SNAP, Supplemental Nutritional Assistance Program, and the WIC, that is a special supplemental nutrition program for women, infants, and children. They also have food initiatives and nutritional education and counseling programs that we, the CDHCs, are happy to engage and connect these communities with all of these available services that programs they have. So as Gloria was saying, we were working directly with the community and helping those kids to get nutritional foods, and talking to those parents to make them aware that their children needs to have a good nutrition so they can develop a good health and good oral health habits.
Okay, Andres, go ahead.
No, you go
All
ahead.
set.
Yeah.
Okay. So
Yeah.
you bring up a really interesting topic, and let's shift the panel conversation there. Let's talk a little bit about what tips can you give our participants today about you have good care coordination programs, but you want to develop these external partnerships to really connect folks, not just to oral health care, but to the types of services that you're helping them find, be it food banks, other social services. So Dr. Cook, do you want to take that first?
Working at a federally qualified health center, I have the access to the whole organization. So, you know, we speak with the peds patients and the OBGYN pregnant moms, and, you know, we have a family affair. And I know it's more difficult and challenging in private practice, but you really have to start with partnership and reaching out and developing a list of services that you can print out and give to your patients. And that could be transportation, that can be locations for them to receive food from churches, food banks, a list of things that will help benefit them. Care coordination usually is just medical. And it was a struggle for my organization to say, okay, dental needs help also, and to train them to be able to come over to dental to outreach to our patients also. We're a part of the health center too. So getting them on board and just opening up the process so those avenues are also given to the dental patients as well. And because they have issues with lights and rent and all the other assistance that other patients have. So it is just a training process and reaching out to the partners in your community to make sure you can bridge the gap of care to help your patients flourish and really become and get the services that they require.
Excellent. Dr. Cook, you touched on something we don't think a lot about at FQHC. So it's not just about external partnerships, but it's about building internal collaborations as well. And so maybe paying attention to the internal outreach, if there's a medical side to your building, and developing some sort of partnerships and intervention that way. So thank you for that. So Gloria, what do you think? How would you, and I know Zufall does a great job with to sort of develop these sorts of internal and external partnerships that give your patients a lot more resources.
Yes, when we were working on our program, we actually did partner with the Y Alliance. They were very helpful. They provided us many tools that we could use to like address all the everything with parents. To make everything easier, they even gave us like a barcode. So to do the application, so the families can select the food, it will take them directly to a portal. Those, and also in addition to that, we have the Snap It in the clinic as well. So we had a lot of help. A lot of people, sources wanted to help us. So, but when the time came, it was really nice to feel like, okay, the community is ready. Everybody's ready. We just have to go and reach out to parents.
Okay. And Gloria, did you find that these outside partners were excited and willing to work with you as an FQHC?
They were.
Excellent.
It was amazing.
Okay, beautiful. And I know Dr. Grover, who has been a dental director at an FQHC. Dr. Grover, what advice can you give our participants around building these sorts of internal and external collaborations?
Well, thanks, Kelly. I just put a little note in the chat. What I found effective at my health center was to, especially at the holiday time, to have a little luncheon, even a potluck luncheon. The staff gets very creative, and we were all great chefs, but to invite some of the key medical people over, let them see the dental clinic, and feed them. They have some food insecurity sometimes with their schedules, their crazy schedules, but this is a way to get their attention and to let them know that the dental world is looking beyond the teeth, beyond the oral cavity, to the totality of the whole patient. This is also a great time for those of you in the health center world to have a little holiday open house, have a little wine and cheese, ginger ale, soda pop, fruit punch with some of the stakeholders, some of whom are on boards of local foundations, and we'll look around and say, wow, there's a lot going on here in the dental department. We better support your activities. So that's just another way to use food. But one of the most innovative ways of pairing oral health and food was from our friends in Nevada at Future Smiles. They had smile kits at all the food banks, and contact information for those parents that would like to reach out and make an appointment. Thanks.
Wonderful. So let's shift and talk a little bit about challenges. I think we all in our work, everyone's busy, under-resourced. How do we address any challenges? And I love Dr. Hook is nodding. Dr. Cook, how do you do that at your health center? So what gets in the way of building, using your care coordinators or even building these partnerships? And how do you address them?
You know what? It is extremely difficult because of staffing. And we're seeing a lot of patients at our health centers. So to ask my staff one more thing, okay, we need to ask about food insecurities. They're like, we don't have enough time in the day. So, and then to engage the patient. Listen, I came here for cleaning. Why are you asking me these questions? So it's an education on the staff. It's an education for our parents. When we were doing the program with the Department of Health, as soon as they walked in, we took their weight. And the parents were like, don't get on that scale. Why? We're here for filling. I do that in peds. So you have to take time to explain the program to them and the reason and why everything is, the mouth is not separate from the body. And this is an overall approach to make sure your child and our families are healthy. So when we start asking those questions, right, about food insecurity, we have to start from a place of making the patient comfortable so they're able to communicate with us. So that was definitely a barrier for us because I had to train the staff. They just want to check. All right, set up. Let's do this filling. Let's go to the next patient. I got 5 more. So slow down and make sure that we're engaging the families that we see. And then, like I said, to incorporate care coordination, that was not a part of our health center. So it was a struggle to say that we need help also, but it is a constant, you want to be an advocate for your department, you want to be an advocate for your families. So just trying to get everybody on board. And like you mentioned earlier, Kelly, about internal support. Getting the pediatric department on board to make sure they make the appointments for them to see us. The OB pregnant moms, they were sending patients out of the health center. I'm like, we are here in the health center. You need to send the patients to us. So, it was a challenge all around, not just external, but internal. But you just have to be the voice for your department. You have to be the voice for the families that you serve. And collectively, you will get to some common grounds and start making really great strides and be able to provide those services, not just cleaning teeth and filling and drilling. We do more than that. We're a public health dentist, and we should be able to support our families with foods, whatever they need outside of the health center.
Well, and that is excellent. And I adore how you're including internal staff as a key stakeholder, because without their buy-in, it's not going to work, is it? Exactly. So I'm going to put the same question collectively, I think, to Gloria and to Andres. What challenges do you all see as it relates to care coordination and developing partnerships with groups who address food insecurity?
What we normally see is sometimes the patients, they were no cooperative in some occasions, but most of the patients, they really cooperate with us when we address the situations. Particularly, I mean, myself, that I'm as an Hispanic immigrant, I can understand all these problems and the difficulties they have to get access to oral health and medical health. So we try to make them aware of the importance of having a good oral and overall health. And also we make them aware that we have resources available for them to be able to solve these health issues and to reach their healthy lives.
Okay, great. And Gloria?
I can talk about a little bit of what Dr. Cook mentioned with the staff. From the internal point, yes, at the beginning, it was a matter of training the staff, they know, like, once we have the patient, the first thing, we have to put the scale at the very entrance of the clinic. So all of the children, okay, before you go to your room, you have to go into that scale. And we even put like a price, like, okay, if you ask to go to the scale, you can go and ask for a price at the end of the visit. So now the patient is pushing the staff, oh, I want my price, well, let me go in here.
Nice.
And then with the staff, we had to, at the beginning, because it's BMI, is the question, the assessment question, the carrier risk. We had to, it was a matter of telling them every week. Then we got some reports, okay, then which ones did we miss the opportunity to do this? So we then had to start addressing the staff one by one, saying, okay, this week you missed this many of opportunities. And we reiterated the message until like everybody automatically just started doing it.
Yeah, that is such a great idea, and that early incentivization is as soon as they walk in. I also think it really sets the tone for a wonderful, exciting visit as well. So that's great. So Dr. Grover, what do you think are some challenges that can be addressed by the use of a CDHC or patient navigation?
Well, I think that establishment of trust and the willingness of the patient to feel that somebody truly understands what they are dealing with, that we care about them and the totality, not from a, we're curious, or not from an invasive standpoint. We're not invading anybody's privacy, but we care about the entire patient. And what mom doesn't really, when they're approached by somebody who understands the challenges that she is going through, understand why we're interested in what that child is eating. We share her concern about what that child is eating. We know how hard it is when after school snacks are so easily obtainable from the party store on the way home from school, or they are, grabbing a bag of Cheetos, going over to a friend's house. These are struggles that we want them to know we empathize with, and just that they can share that with us, I think alleviates their stress, and then they're more willing to listen and to collaborate with what we have to suggest.
Excellent. I kind of want to shift topics a little bit to food insecurity itself. I heard you mention there's a ton of not great food out there, and there's a lot of easy access to that. But at the same time, we're finding patients are food insecure. And I know in my own work in high health disparity neighborhoods, food insufficiency and insecurity was so much worse than people thought. There were a lot of hungry people out there. So Dr. Cook, I'd like each of you to tell us what you see in terms of food insecurity at your in your organizations with your patients.
We utilize our food banks a lot.
Okay.
We have several churches in our community that disperse food throughout the week. Different organizations that we provide that information for our patients. And what we're noticing is that the need is increasing in our communities. A lot of people are not making it through the month with making sure that the families have enough food. So we're very grateful that we do have those partners we can refer to. It is important. I have our care coordination. They did our care coordination department that we work with. A couple of them actually keep food in the department. So we can just put a basket together for some of our patients who are really in need at that moment. And I think that's just incredible. And it just speaks for the quality of people that we have working for us at the health center, because you truly have to give back and be able to provide the services that these patients need. Because some of our patients come with not just medical, just not the physical, just not the behavioral health issues. It is just a day-to-day struggle to survive. So that has helped. Just once again, going back to the partnerships, going back to the people in your organization that can provide that little extra help. One thing that I found really amazing is that one of the counties I worked for, this was a couple of years ago, they got a grant. The corner stores, the bodegas in the area got a grant to be able to input the refrigeration needed for fresh fruits and vegetables. It was a big grant. Our Cory Booker pushed for this grant because coming from an area, Essex County in New Jersey, that area was really in need. It was a food desert. So the grant was given out to, I think, 25 corner stores. It was a great input. They had the refrigerations. By the end of the year, the fruit and vegetables were gone, and it was used for other things. Wow. Because no one was buying the fruits and vegetables. That's not what they were going to the bodega for. So I think that this is a bigger problem than we think.
Yes.
And I think everybody can do their part to start educating our patients on proper nutrition. It affects everything. So that was amazing. I think they're actually doing a paper on that grant, but it was just amazing to see that you go, and I know one of the bodegas, and I went in and they had alcohol in it now. That's not what the refrigeration was for. So it's just kind of sad. And I just think that our grant for the Department of Health with the obesity grant is over, but my providers were so excited about the process, they still continue to give that information out. So it just has to be part of our delivery of care at this point.
And I think that you gave such a practical tip that you actually, if somebody needs it right away, you have it accessible at your center. And that is a great idea, actually. Gloria, Andres, what about you? Do you think, are you seeing a lot of food insufficiency in your center?
Yes, I was checking the data from the Census Bureau of the United States Census Bureau, and it was showing that in 2020, the food insecurity was at 7.4% for the whole United States population. But in New Jersey, in New Jersey was 7.4%, and in the United States was 11.8%. But the problem was that these numbers skyrocketed after COVID.
Mm-hmm.
And now we have an increase almost double in the whole nation. And in specifically in New Jersey was 2.6 times. So now we are at 19% of households with food insecurity. So that's a really challenge problem that we have to try to address. And that's we observe in these patients here at Zufall that most of the people that Hispanic population here at Zufall is the ones that have these food insecurity problems. According to the United States Census Bureau, 3% of the white people had issues with food insecurity, while 17% of Hispanic population has, and 17% of African Americans have problems with food insecurity. So we have a high population of Hispanic people here at Zufall Health Center. So we can see that a lot of, a great percentage of patients has problems with food insecurity.
Gloria, any comments to that?
So what I want to say is, it's mainly education. We've seen after the pandemic, a lot of, it was in conjunction actually. It came hand in hand. We saw an increase in the BMI percentage of the children. And at the visit, when we did the carrier risk assessment, the new carriers on RICO, it increased the same way as the BMI. When we actually try to talk to the parents, I guess because of the pandemic, it was easier just to go and get something from the dollar menu at McDonald's. And it was a matter of going back and teaching them. We grabbed the healthy plate method. We show them, okay, this is how much it has to be. And what we tell all the parents, remember, the pants should be shorter before tighter, because that means they're growing and they're growing at a healthy rate. It shouldn't be tight first, then shorter. And it's just a matter of educating parent. That after that part, we started seeing a little bit more of the changes in the numbers that we got after opening the clinic again after the pandemic. And we're still working on it. It's not as great as it was before, but we're still targeting and educating.
Excellent. And yet another practical tip. And I think that's a great use of a health literacy by simple, right? Pants should be shorter and not tighter. So very nice. So the last question for the panel, and then we'll have a little time to take from our participants. Starting with Dr. Grover, what do you think the future of care coordination is post-COVID?
Well, I think that it is brighter and more relevant after COVID because people are coming back out, and I think they want to be connected to what they have probably been missing during COVID. And I think that as this curriculum continues to grow and expand, it wasn't too many years ago that we only had 40 or 50 grads of this program. Now we're closing in on 900. We've got the Indian Health Service soon to be offering this. So I think the recognition of dental case managers is just growing. And I think that particularly with the physicians looking at their health outcomes, particularly for diabetics and pregnant women, I think that this is a really key area that we're going to see grow and grow exponentially. Thank you.
Excellent. And Gloria, Andres, what do you think? What's the future hold?
I think we're going to continue with these programs, particularly with the help of the National Health Department and New Jersey Health Department of Health, to help these minorities to overcome these problems that barriers that they have to access to dental health and oral health and regular overall health.
Okay. Gloria?
I think the future is going to be more integration, medical and dental. With the body is just one body, it's not a mouth and a body. And that's how we have to see it.
Excellent. And Dr. Cook, I saved you for last because I think it's very interesting to get a CEO perspective on what do you see the future of dental care coordination to be in the future?
I think it's bright and we have so much opportunity. I'm going to leave you with this story. So at the last health center I was at, our care coordination team did not do anything for dental, but my team had a hard time reaching out to a patient. We suspected cancer, and we were sending him for to the oral surgeon. He kept coming back for the same problem, pain, pain, pain. We were like, we need you to go to the oral surgeon. He did not go. So I got care coordination, and they were reluctant, but I was like, we need help with this patient. So they outreach, and come to find out the patient was homeless. So we got them to the oral surgeon. He did have cancer. He did receive the treatment needed for the cancer that he had. And we got him housing. We got him connected to his family because he was estranged from his family for over 20 years. So it showcased how important that connection is to help dental and help our patients get the services they need and connect them with other services that they may need to help them to be, really engaged in a part of their community. And he just felt like he was an outcast. He didn't want anybody to know. He didn't have phones. So we're giving him paperwork, do this, follow up. And he had no clue. So that connection is important to make sure that we provide those services outside of the medical and dental. Social services are just as important. And I think that we have an opportunity here with our dental community health workers to really do the work that is needed. And it's just not the dental work, it is the work for the patient. And I'm excited about it. And we have so much to look forward to. So
we're excited too. And I just love that there's such a business case that really supports. There's the social case, but there's the business case that really supports how important dental case managers are, community dental health coordinators are. I'm going to turn it over. We have one question. Where a commonly accepted definition of food insecurity is food security exists when all people at all times have physical and economic access to sufficient, safe, nutritious food that meets their dietary needs and food preferences for an active and healthy life. Do you see your work going beyond patient education to advocacy? So now we're getting into policy to create policies that impact access issues. And wow, how do we cover that in the 5 minutes that we have left? Dr. Grover, would you like to start?
I think that an opportunity here is for the patient voice. The consumer advocates and all of the policymakers listen to statisticians and very educated folks, but I would like to see more of the consumer voice weighing in here on this definition. I just think there's a deeper meaning here to this term. That's just my thought. Thank you.
Okay, Gloria, Andres, what do you think? How can policies sort of impact what we were talking about today?
I mean, we try to get policies that help us funding these programs. So that's the most important thing, because without money, we cannot be able to do this program. So that's one issue that we have to address.
Okay, Gloria, any comment?
We are the people with the knowledge. We know what is going on out there, know what the need is. We need to be their voice. We can talk to and with the Department of Health, we can talk to the bigger people, but I feel like we also we know firsthand what's going on out there. So I guess it's them and us looking for a change.
Okay. And Dr. Cook.
I agree with every comment that was just made. The bottom line is advocacy begins with the voices of the people. And collectively, we need to come together. And like I said, the partnership, your partners, your patients, and the providers, we need to come together. And we, as FQHCs, we go to the state capitol every year, and we beg for this, and we need this, and this needs to be a part of the agenda. So just being out there and having a voice for the patients we serve will make so much difference in our communities. And we can never stop being an advocate for our patients.
Okay, perfect. And I like to end the session, and I want to bring folks' attention to the CE link. We've got a few minutes. What's for each of you, what's one takeaway you would like our audience to know today? Dr. Cook, let's start with you.
The one takeaway is that, and all of us have echoed this, the mouth is a part of the body. So everything that goes through the mouth, nutrition is important because that helps provide nutrients for your body, but also keeps your mouth healthy too. So it goes hand in hand, and be an advocate for the patients that you provide services for.
Okay, Gloria.
Advocate us as the healthcare providers, really trying to understand where that patient coming from, and trying to put ourselves at that level. Maybe we think, okay, they had a bad day, but maybe there's something else going on, or maybe they don't understand. For example, in my case, I've taken pencil and paper and draw everything to make them understand. So really going to their level to meet their need.
Excellent. And Andres, who works solely as a CDHC.
Yes, as Gloria was saying, we have to, help the patients is in health literacy, and advocate them to seek this help for these services that we can provide them, so they can know that we are there for, to help them to achieve their good oral health and good overall health.
Excellent. And Dr. Grover, to end us today.
Well, I think that going forward, what I would like people to take away from this is that the CDHC program can be a strong foundation for not only this, but some of the other issues that our patients deal with. And so again, it's offered through Zufall. It is an online curriculum, and we've just seen a spectacular example of one of the graduates and the wonderful work that they're doing. So we appreciate everybody's time today. Thanks.
It is so I want to thank all of our participants today. I certainly want to thank our panelists, Dr. Cook, Gloria, Andres, Dr. Grover. Please look at the chat, take the survey, follow the link to the CE. I believe this session will kick you out of its Zoom, and it will take you back to the main session or whatever session you're going to. Thank you so much for spending the morning with us. We appreciate it, and have a great rest of your conference.
Thank you.
Thank you,
Kelly.
Kelly. Thank you,
Thank you.
Dr. Grover. Thank you, Gloria.
Thank you
Thank
so
you,
much.
Dr. Cook.